Welcome. My name is Rama Khalsa, and I'm from Behavioral Health Concepts. And you are at the second of 5 special performance improvement project trainings that we're doing for the Drug MediCal external quality review. Our goal is to help every county be wildly successful with implementation of their PIPs, their performance improvement projects, as they roll out the Drug MediCal benefit. And many of the counties are right now getting ready to launch services. And so we're hoping to make this easy to be able to do these PIP concepts and have feedback from us and technical assistance. So our first video, which is on our website, was an overview. And the second one is actually an example that came from a county, and we will be doing a lot of example PIPs because we feel like they're more grounded in what you deal with day to day. And we felt like it would be more helpful and provoke more thought about how you might approach it in your individual county with the challenges and opportunities that you would have. So welcome, and we do have materials as well as the video that you can download when you use this to train your staff. And these will be maintained on YouTube and our website for you. We're going to transition now to Amy McCurry, our PIP expert from Missouri, who knows the federal protocols the best. And she's going to help us walk through this sample and give us some of the highlights, and we're going to debate why some of the features are good and some could use improvement, and some of the struggles that the counties go through at different stages. So with that, I'd like to introduce Amy McCurry.
Thank you. Okay, so I think I want to start at the beginning with a little bit of a discussion about how performance improvement projects fit into your quality improvement program for your organization. And what we want to talk about is the idea of continuous quality improvement. And in healthcare, continuous quality improvement starts by identifying problems and then implementing and monitoring solutions or corrective action, and then studying how effective those might be. So when we're talking about performance improvement projects, we need to first foster a quality improvement culture within an organization, so that you think about how when you identify a problem, that you might then identify solutions and be able to monitor the effectiveness of putting those solutions in place. And that in and of itself is what a PIP can do for you for a specific issue. So if you have an issue, a challenge, a barrier, or an opportunity to improve, what is it? How do you identify it? You want to think about, first of all, how something could be improved. That would raise it to the level of a performance improvement project. If it's something that you can improve by obviously doing 1 or 2 things, and you know what those are, that is definitely not a performance improvement project. The idea of a performance improvement project is that you have an idea of what might be causing your issue, but you're not quite sure exactly whether that particular thing that you might be able to implement will improve the issue or not. You may have multiple issues that you need to look at, and you want to be able to track those. And so that would be why you would want to make something a performance improvement project. So let's talk about how you get to what we will call a PIPable idea. Yes.
Good idea.
So let's talk specifically about substance use treatment systems, and how can we get to the ideas of what might be something we could tackle in a PIP format. Let's think about how would you identify and raise these issues that need to be improved. And the number one thing that you will need in order to decide if you can make something PIPable is data. So you're going to need to be able to collect information so that you know the extent of the problem as you begin, and then collect that same information so that you know if any of the interventions that you put into place make a difference or a change. So that's the number one thing. If it's not something that you have data for, then you need to figure out how you can get that data. And if it is something that you can get data for, then it is something that you possibly could turn into a PIP. So.
And I just want to say that there's so many issues that we've been discussing as part of the implementation of the drug MediCal organized delivery systems. There's a wealth of opportunities, both on the clinical side as well as on the administrative operational side. So your staff, your programs will have lots of suggestions and thoughts for you, and many of those are PIPable ideas. And you do start, though, with data.
Yes.
And really investigating your data and seeing, is your concept of what might be going on correct?
Correct. And Rama alluded to a good point also, that you need to not look at this necessarily in the bubble of your management team.
Right.
Think about how your staff, how your clinicians, how they might be able to send you in a direction of something that may benefit the clients. So involve as many of those folks as possible. So then we can talk a little specifically about performance improvement projects, and we cover this particular topic, the purpose of PIPs and what PIPs are, more in depth in our first video. So if you're really at the beginning and want a refresher on that, be sure to check for that video as well. But the purpose of a PIP is to assess and improve processes, either clinical, administrative, or operational, and thereby improve outcomes of care. So all of the information that we talk about when we're talking about performance improvement projects can be found in the Federal Code of Regulations in 42 CFR 438-240D, where they define PIPs as having a focus on clinical or non-clinical areas. And this is something that's important because a lot of times folks think that they have to look at a specific project or a specific PIP from the clinical or non-clinical area. They're not thinking about, they're focused on one of those. They're not focused on both of those. So a clinical PIP might target things like prevention or care for an early stage of a chronic substance use disorder condition, maybe high volume services. Some of those could include methadone or intensive outpatient. Okay, so those are things that you may even talk about high risk type of procedures in a clinical PIP. And a non-clinical PIP would probably focus more on things like coordinating that care. So not necessarily implementing a new clinical intervention to improve that care, but maybe coordinating that care either within your organization, possibly depending on how you're structured, could be between one department and another. You could be coordinating care also with physical health outside of your organization. So that would be an example, and that would just be the coordination of the care, not the actual delivery mechanism of the care. And then non-clinical could also include things like no-shows, early dropouts from care, and timely access to care, getting folks in sooner. So not the actual clinical delivery, but the things that impact the ability maybe to deliver that.
Right, and those processes can't be underestimated in terms of their importance, because the timeliness to get to care is shown as one of the most important issues with substance use, is that treatment on demand and treatment when the person's motivated and ready is critical. So if your system can't respond quickly and get people to care in a timely way, you're going to lose a lot of opportunities to help people. And so there's many processes related to access, timeliness, and even the clinical relationship, the quality of the clinical relationship, and that bonding between the client and their counselors, that all have a lot of impact on the best treatment. And we know that the community and the counties want the best possible treatment. So lots of opportunities for good PIPs, especially launching this new initiative.
And the one thing that we would remind you about those non-clinical PIPs is that they need to have a clinical outcome. So you
Right.
need to be able to prove, even if your intervention is something non-clinical, you need to be able to show that that improved the clinical outcome, either someone receiving care sooner so they're able to get help when they need it, someone moving down possibly in a level of care, that type of thing. That would be the outcomes that you would need to link to what you do for a non-clinical PIP. So that's an important thing to remember when you do that. So let's get right into the CMS protocol steps that can be found again in 42 CFR 240. The first thing that you have to think about is selecting a study topic. So we have a PIP example that we're going to use today, and the topic was selected to improve outcomes for dual diagnosis youth.
Yes.
So when you're selecting a study topic, you need to think about, why is this important? What is this impacting? What is happening with dual diagnosis youth that makes it something we need to address? So the first thing you need to do is think about data. So what type of data do you have that'll define what the problem is for these dual diagnosis youth? Rama is well versed in these examples of what the data is, but you know, the first thing you'd want to look at is just the prevalence of substance use disorder indicators, and you can find those nationally, regionally, statewide, and by your county itself. So what are some of those examples?
Well, one of the things that you will find is every county and state has NASDA data. That's the National Survey of Substance Abuse Treatment Services. And SAMHSA has that online. So if you want to look at some of the national data, in general, youth have about a 55% take-up rate, if you will, around substances between the ages of 18 and 25. So that's obviously the riskiest period. And many of them are dual diagnosis, meaning there's co-occurring depression, anxiety, or other mental health issues. And so clearly the national data shows that that's a time where you really do want to focus in. And locally, you have to bring it home. You have to look at, so what is going on in my county? You want to look at your CalOMS data. You want to look at your service utilization data, and you want mental health and SUD to compare, if you're going to target dual diagnosis clients, the clients that have both a mental health diagnosis as well as a substance use disorder diagnosis. And if you ignore either one of those treatment needs, your outcomes are probably not going to be that great. And so this county said, you know, we're doing a pretty good job getting to mental health, but not paying much attention to the substance abuse side, and our outcomes need to be improved. And so there was a lot of interest in improving that. There's also another wonderful tool that all the substance use programs use, which is the 7th, 9th, and 11th grade confidential youth surveys that are done in the schools. And these are a very powerful reflection of what is going on in your community, and are those problems real for my community, and at what ages, and even what school districts. And so there's a wealth of information built into your care system already, and you're able to expand that to other tools if you need them.
So that gets us to the idea of your study topic needing to show an impact.
Right.
So just from the information that Rama just alluded to, we know that nationally 55% of kids start using some sort of substance during the ages of 18 to 25. So that's an impact. Nationally, that's a large impact. So then you need to drill that down though and see, what is the impact in my county, in my area? And so in that instance, then you want to look at the school surveys, your own CalOMS data, see what the impact is in your county, and identify kids who have are using substances, and then we want to look at the dual diagnosis. How many of those kids that indicate they're using substances are also diagnosed with a mental health condition? And we can see that on the county level, we can see that on the regional level, however you want to impact that. So remember that when you're looking at putting a PIP together, you need to have an impact, and it needs to be a significant one according to the CMS guideline. I don't think we have a problem reaching the level of impact in this particular instance. So that is definitely an area to look at though. And then not only does the impact need to be large on a scale of wanting to impact a lot of folks, but do we have the opportunity to impact something significant for the individual? Right. So it's looking at things like, yeah, a lot of people, are involved, but are we able to do something to change that? So is our focus, our intervention able to do something to change a significant amount? Right. If we put in an intervention that we have 55% of kids using, only gets to, 1 or 2% of those kids using, then that doesn't meet the threshold for having an impact on the population as well. You need to have a significant issue, and then you need to be able to impact it in some way significantly as well.
And one of the things I just want to mention is that these issues for youth have been particularly underserved in the last decade as mental health got EPSDT funds and substance use had very, very, very limited funding opportunities. Detox was not funded, residential was not funded, case management was not funded, recovery services were not funded, and so you had this very narrow band of limited outpatient. And so what we are hearing and seeing is that this issue of underservice of youth is a fairly prevalent one, and we're anticipating that many counties will be looking at this as possible areas for quality improvement. But as Amy said, starting with your data and starting looking at your baseline.
Right. So let's talk specifically about St. Teresa, or we did Santa Teresa County is the county that we have changed the names to protect the innocent for this particular performance improvement project. So we will be talking about a fictitious county that actually we have some actual data for, but we're going to talk specifically about that. And so in Santa Teresa County, the data from their school survey showed that the average use rates were 39 to 68% for the kids in those age groups. So we know specifically in Santa Teresa County that they are well in line with the national data. And then we also see dropout rates from mental health counseling. So kids who start mental health counseling but do not complete their treatment plan, do not move to the next level of service, or do not graduate from the program is around 57%. So a lot of kids are starting treatment and not completing it.
Yes, and it's not uncommon, I think, for mental health counselors to not actually have a lot of training and background in the substance use area. And so there was kind of a identification of this as an incredible need for the kids, and yet the therapists felt like they needed help, they needed a specialized substance abuse focused program if they were going to address the kids' needs.
Okay. And then we also saw that we had the 39 to 68% of kids who were using, but that 30% of those indicated they were at risk for a serious problem. So that is a significant amount. We have a lot of kids that might be experimenting with drugs and that kind of thing, but then of those that are experimenting, 30% of them have indicators that they could have a serious problem. So this is something in this county that is definitely ripe for an intervention or some kind to improve. So
lots of good baseline data
yes.
showing red flags, got a problem here, and then you start thinking about, okay, how can we take this apart and approach it systematically?
Mm-hmm. And then so we have a problem, we've identified the problem with, also we have some information in the slides about juvenile offenders having the problem as well. And then to top it all off, we have a very low level of utilization of the SUD programs among this population of youth.
Right.
So, so it looks like there is a poor link between access
Mm-hmm.
and engaging these kids. So we have an issue with both of those two things in this particular county.
We do, and it's not uncommon, actually, to see the juvenile hall particularly have a very high percentage of youth that have substance use issues. And yet, there's often very limited, if any, substance abuse treatment for those kids in the juvenile hall or even in organized aftercare programs.
Okay.
So many important things were identified as part of the research for this PIP, which is one of the good things, is you want to really thoroughly research your issue so you have a good sense of where you can make a big impact and really make a contribution to your problem.
Okay, so they've identified the issue, and then they looked into their own system to look at some of the gaps in care that they might be able to remedy.
Yeah.
And they found some things that are in your slides, but maybe you can talk briefly about
Sure.
some of the ones that specifically are targeted with this PIP.
They also identified that they had no systematic screening for the kids to link them to substance abuse and really any of their systems. That screening, because the youth survey in schools is completely confidential and they did not want to compromise that, you need another kind of screening tool that would let you say, okay, this youth is in need and we do want to try to reach out to them and engage them in treatment. So they did the screening as one of the components that they needed to look at. They also said, you know, our linkage between mental health and SUD and probation, SUD and mental health ain't so great. So there are no systematic, really good, effective referral patterns, or if you just give a phone number to the youth's parents, there's no follow through. So we really need to improve those components as well. Even when it is identified, there's very little low uptake, low engagement. They also did a chart sample and looked at who was dropping out of care, who had incomplete care. And this happens a lot where a teenager goes to mental health counseling and then all of a sudden they won't go anymore. They just basically say, I'm done, Mom, you can't make me go. And they drop out of care. And when they did a chart sample of that group, they saw that a lot of those kids had substance abuse on board as well. And really it wasn't being addressed, you know, as part of the treatment program because of the expertise of the mental health staff. And obviously we've already talked about the fact that confidential school surveys showed a need as well as juvenile hall records.
Okay, so the next thing we need to talk about is the goal of the PIP. When we've identified what the issue is. We've talked a lot about what data is available. So what do they want to do? What does Santa Teresa want to do in this PIP, and what do they plan to do? We'll come after that. But first we want to talk about what's the goal. We know we have this issue, so what do we want to do?
Right.
So we have defined the goal in this instance as reducing the functional impairment due to substance use among youth in schools, juvenile justice, and behavioral health outpatient services in the county. So that is our goal. And so what we need to do in order to address that goal is put together a team of folks in Santa Teresa who can address these issues. So if we're trying to get to some things to remember as we're looking at kids in schools, kids in the juvenile justice system, and kids already receiving behavioral health outpatient. So we need to assemble a team that has these particular folks on the team. So folks who deliver that care need to be on that team. We also need to talk about including other stakeholders. There might be some kids that have graduated from a program that you might be able to include on your team. That might give you some insight, some parents, that those kind of things. And so when you're talking about putting a team together, you need to think about the folks that would be on that PIP team. So now we've got our goal, we've got a team developed, we've decided we want to reduce functional impairment for kids. And so now we need to put together a study question. So the study question should be thought about and stated in a way that supports Santa Teresa's ability to determine whether the intervention they put in place has a measurable effect on the population. So what they need to do is focus on the outcomes for the kids in this instance. So when we're focusing on the outcomes for the kids, we're focusing on early identification of those youth who might be at high risk. Yeah. So that involves needing a comprehensive screening of the kids. That also we need to focus on increasing the engagement of those youth. And we talked about how motivational interviewing could be a tool to help with that. And then we want to see scores increase or decrease on different scales depending on whether that's good or bad on the scales that they're looking at. So that would be the thing. So when we define a study question, we need to look at it and think, will our intervention improve engagement and then it result in improved outcomes for the kids? So will our intervention decrease those drug use patterns and improve outcomes for the kids? Will systematic screening result in improved identification and engagement of the youth that are in need of SUD treatment? And how can we prove this? So we're talking about, in this instance, they identified they'd like to see a 15% increase in unduplicated clients in youth treatment. Okay, so you have a slide that kind of details exactly what the wording for the study question in this instance was, but you want it to be client focused, right? And you want it to go to client outcomes. So in this instance, we've gotten there. And we purposefully are not revealing our intervention at this point, but when you do have an intervention named, if it is a named type of program, you can include that specifically in your study question. So, so this is what we want to do. We want to improve these things. So then the team of folks got together and said, how are we going to do that? And someone on that team, not sure who, someone on that team had participated in or had heard about a specific intervention. And so do you want to tell us a little bit about the intervention that they had discussed?
So with the team, you start out with everybody who you think can contribute to understanding the problem, understanding the data, and also understanding what some opportunities for improvement would be. And so they did have an initial core group, and then they built on that with substance abuse expertise to say what is a good, ideally, evidence-based practice that might help with engagement of this group and involve them in successful treatment and successful outcomes. And so after discussing it, they chose the Seeking Safety treatment program, which is an evidence-based practice, and it can be done in individuals or groups, but it's very user-friendly to youth, and it's very understandable and non-jargony, and the outcomes with Seeking Safety are very good, and it's trauma-informed care. And many of these youth, particularly the ones in juvenile hall or child protective services, have had some level of trauma as well, and that definitely enters into the treatment, both on the mental health side and on the SUD side. And one thing you know about substance abuse treatment is that it can lead to very risky, unsafe behaviors. And so one of the themes in Seeking Safety is maintaining good boundaries and understanding how to keep yourself safe as you work towards recovery and a successful life path. And fortunately, also, there's a wonderful manual available online that you can get, both hard copy and not, that lets counselors work with youth and parents even, and it has lots of tools, very practical, easy to remember things. And so there's many elements of this treatment that would lend itself to this partnering with juvenile justice and mental health. And so the group said, let's try seeking safety as a module that we could offer these youth after they're identified, and through motivational interviewing, we engage and hopefully link them into a group. The other thing you probably all know already is teenagers tend to listen to other teenagers. And there's something about the group dynamics in these sessions that's very effective at building peer support, motivation, insights, and it's very different than just doing individual therapy or group therapy with your parents. It's the uptake and the engagement and the outcomes are very strong. And so I think the team was well-informed in terms of picking this particular intervention to test for this particular group.
Okay. So they've identified an intervention or a program that they would like to use, seeking safety. And then there's some more information in the slides about some of the key principles. Rama did a good job of sort of explaining some of those, but I think that a lot of that information is contained in the slides, it would probably be easier for folks to read those and investigate those on their own. But a lot of it is about integrating treatment.
Yes.
A lot of it is about focusing on specific ideas, specific milestone type things, and just, you know, getting through one thing, not placing a lot of weight on specifically with teenagers, on them at the beginning. So, we sort of talked about the study question and how the study question was defined for this particular PIP. But we want to reference you back to video 1, which gives you some information about how you could come up with a study question if you have an issue that isn't this issue. So some more general information. So again, that's in our first video, and that might be a place to start if this particular study question doesn't work for you, or if you want more information about how do I write one, how do I make it simple, how do I make it measurable, that kind of thing. So let's move on then to step 3 in our CMS protocols. So in step 3 is use a representative and generalizable study population. And of course, in this instance, that we have lent ourselves to using the idea of youth, and specifically in Santa Teresa County, they have decided to look at youth ages 12 to 18.
Right.
Okay, so, and then the idea is we're looking at clients who are receiving outpatient mental health services that meet those age criteria, or all kids who are in middle or high school, so that indicate on a survey that they have substance use issues or the tendencies for substance use issues. And then we're looking at the juvenile justice system for those ages. So that is our population, and we're not excluding anyone in that age group who meets those particular parameters. And you know, if Santa Teresa could decide if that is a lot of folks for them to deal with at the beginning, they could decide either a certain score level that they would like to work with to begin with. Maybe they want to target a higher risk population to begin with, or they could talk about biting that off for one geographical area in their county, but they're not excluding folks based on anything other than those kind of ideas, and that would just be for trying to reach a population that would be manageable. So.
Yes, and so in a big county, and there are many big counties in California, it's not uncommon to look at, we're going to beta test this idea in one region. If this works well in this region for our youth, we will expand it to the next region and their school districts and their outpatient mental health population. And so depending on the county, you can start with a smaller group. You really can, with fidelity, test your intervention and have good data, and then grow it out to scale throughout the county to all your youth. So this is one of the things to just think about. One of the common mistakes we see is people will take a really good idea, but they'll try to implement it in such a grandiose, complex way over such a large number, they just don't have the capacity to do it. And it kind of falls apart because of that lack of resources. It's better to go small and do it really well, and then thoughtfully examine your data and then decide if it needs to go to scale, or maybe you need to tweak it a little bit to make it more effective, and test that and then bring it to scale. So I think this is one of the learnings that Amy has shared with me, is that folks want to do the best for everybody, but starting out with a really big, complex performance improvement project can sometimes sink it without intending to.
Okay, so if we are talking about incrementally putting the PIP together and starting at the beginning, starting at the beginning small and working to larger. One of the reasons you mentioned was capacity, and that's what I wanted to talk to bring folks back around. Remember, in this particular PIP, you are gathering a lot of data. Mm-hmm. There are a lot of data sources that you're having to pull information from, and so you want to think about the capacity of your ability to keep up with that data.
Right.
Because you want to pull that information often enough that if something isn't working for you, that you can make changes. So if you're doing that, then you need to think about the capacity of the staff to be able to pull that information and to look at that data. So that's a thing that you need to look at. Another thing is that PIPs can last for a length of time. So let's say you want to start this particular PIP out at one school district, and there's 5 or 6 school districts in your particular county. Well, you might consider doing this thing for 6 months to a year at this one school district, and then phasing it out as you go forward to see if there are things that make the school districts unique. You may have to tweak some things when you're doing it when you move it out to the next school district, but you have the ability for a PIP to be tested and tried over a period of time. Now, when something starts to become part of your day-to-day operation, and we're going to do it at every school district, it's no longer really a PIP, it's just part of your continuous quality improvement.
Right.
So, but that gives you another opportunity to phase in is over a period of time. So don't feel that you're constrained by some arbitrary time frame. You can move this out over that phase. So, okay, so if we move to Step 4, we want to talk about selecting study indicators. What are we going to measure? What's going to tell us whether or not what we're doing is effective? So a study indicator would be a quantitative or qualitative characteristic reflecting a discrete event or something that needs to be measured continuously. So they're used to track performance, and they're used to look at things over time. So you want to have a baseline. And then you want to have things that you can measure over time and compare to that baseline to see if you have improved. So when you're talking about things that might indicate success, you want to think about barriers to your success.
Right.
Because you want to effectuate those barriers and measure changes in those barriers as an indicator. So say you've identified the fact that in the SUD issues aren't being addressed by the mental health providers when they
Right.
have kids with a dual diagnosis.
Mhm.
So how can you have an indicator to show that you have put into place ways that those mental health treatment folks are putting those SUD issues to the forefront? How would you measure that? So that would be an indicator, and the reason it's an indicator is because you can't do the outcome of having kids receive quality treatment and move down in both their mental health issue and their substance use issue, move down in the level maybe of care or reach recovery, which is the
Right.
ultimate goal, unless you have staff who can deliver those. So you need to have that as an indicator. And then we talked about gaps.
Gaps.
And so those would be indicators. If we close those gaps, those would help to indicate that we're on the right track, and they should show that our intervention, they should show that our outcomes are to come.
And just in terms of those gaps and things, Cal OMS has a lot of indicators built right into it. It has issues of frequency of drug use in the last 30 days. It has school attendance. It has criminal justice events. And so you have built into the state requirements both the baseline, which you must do all of those when you open a case, and you can do them periodically and at discharge. So there are some architectural structures right there to look at some of those benefits of your treatment.
Another indicator for this particular instance would be just measuring the kids who drop out of treatment.
Right.
So that's a very simple one, but that would be an indicator of your success. You would,
Right.
if we have, and I'm not remembering what we said the original dropout rate was, 57%. You would want to measure that indicator, because as you put your intervention in place, you would expect that the number of dropouts would decrease. So that would be
Right.
an indicator that you could look at as well. And we haven't mentioned this, but the plan for this particular video is that it will be accompanied by the slides that we are looking at on the table, but then it will also be accompanied by a completed PIP submission tool, which will detail all of this information, and which will show you in a write-up how we would expect as the External Quality Review Organization to see this information detailed. So those things can work in concert and help you to see this. So when you're talking about study indicators, you want to talk about what are you trying to determine? Are you reaching all the kids to be screened? That would be an indicator. How many did you start with? How many are you screening now? Look at your baseline and your reassessment scores. And then when we're talking about the seeking safety, there's an adherence scale in seeking safety. And so that would be an indicator as well. You would want to look at that score sheet. It would evaluate the clinician's fidelity to the model of seeking safety. So again, that would be another indicator. So for Santa Teresa County, we want to see therapy dropouts go down. We want to talk about the frequency of kids' drug use in the last 30 days. Again, one would want to see it go down.
Go down.
And then we want to see incarcerations in the county for juveniles to go down. So, but we would want to see new cases opened for substance use disorders for kids to go up. We would expect there would be more of those. And we want to see things like school attendance and average grades go up.
Yes.
Okay. And then, of course, rates of participation in the intervention program itself, we would want to see those improve. So those are the things that we have put as indicators for Santa Teresa County. And again, you can see those in the submission tool, how we would write those up. Step 5 in the CMS protocol for validating performance improvement projects is sampling. And in this particular PIP, we're not utilizing sampling. And sampling is something that at the beginning, while you're putting these PIPs together, we're really not encouraging folks to do. If you feel that there is a reason that you need to sample a population, please contact your EQRO reviewer, and that individual can help you with whether or not you should be sampling. But, basically, in order to sample, we need to make sure that we are collecting a portion of the folks that is
Right.
significant. And it needs to have some statistical significance testing in order to determine that that's happening, and that may not be something we're ready to do yet. So you can do it, but we need to caution you in that area.
Yeah, caution and offer TA if you feel like you really need to or want to, because it is an area you can get into trouble easily, because it involves a lot of research knowledge if you're going to do it in a valid way.
Okay, so step 6 in the CMS protocol is reliably collecting their data. So to start with, let's talk a little bit about how data must be valid and reliable. And valid data means that the information that you're collecting, the information you're collecting is accurate. So the data is measuring what you intend for it to measure. Mm-hmm. Is it accurate? If you're talking about collecting apples, are you collecting apples? You don't want to get those oranges in there. Is it reliable? So that indicates it's repeatable. So as you're measuring your data, can you do it the same way every time so that you can have consistent results? So those are the things just to keep as a parameter when we talk about reliably collecting data. So in this instance, we have a lot of data sources that are collected the same way.
Yes.
Often and have been tried and true. So things like Cal-OLMS, things like the ASAM and the Fidelity tool and the Seeking Safety are all things that have been proven to be reliably and validly tested.
Yes.
So in this instance, if this is a program you're thinking about doing, you've got a leg up on folks who are starting from scratch. So that's a good place to start. But let's talk more maybe specifically about the things that can affect you, even if you have these reliable sources and valid sources of data. Let's talk about how you could get yourself in a little bit of an issue, and things you have to be aware of. So who's collecting the data for you at Santa Teresa County? Is this somebody who has the requisite knowledge to be collecting this information?
Right.
Does it require someone with a certain level of expertise? Does that person need to have a way of identifying that when they pull something this quarter, it looks so much different than last quarter, that they would know they may have hit the wrong key, or they may have included a population that you didn't look at before. So you need to look at that. And so you need to have a protocol for how they're collecting it,
Right.
who's collecting it, and who will be then analyzing that information.
And sometimes it's helpful also to have somebody who's kind of a quality control person over the data system or in IT or in your quality division, who will just do some sampling of your data sources to look at consistency and look for any bizarre, aberrant stuff. Because it can happen accidentally, it can happen just at the data entry point, and you don't want invalid data in there. And so someone periodically to just look at the data and go, okay, this looks good, this looks consistent, psychologist Smith collected it and he has plenty of expertise in Cal-OLMS and ASAM, and so we feel like this is a good sample,
Right.
a good group. So that is really important, because sometimes people will get down the road and then go, something's wrong with this data, and we don't know how to interpret it. Well, you don't want to find that out when you're 6 months into your PIP.
Correct.
That creates all kinds of disappointment and frustration, and the earlier you look at the quality of the data, the better.
And another thing that will help you with that and is required in our data submission tool is that you have a plan for how it's going to be collected.
Right.
And before you ever collect the data, you've identified who will collect the data, how often will they collect it,
Right.
when will it be pulled, and then when we see results that are not what we expected, what do we plan to do about that? So having that plan ahead of time And then being able to react when the situation comes up is another area that is very helpful in this type of program. Because you can identify the data to be collected, you can identify the sources and how often you'll collect it, who will collect it, and then you can identify the instruments that will be used to collect that data. So that would be how you would put together a data collection plan. And again, this is an area where you need to talk about, if you are sampling, are we collecting for the whole population or part of a population? So this, again, would be where, if you were sampling, that would come into play, and why you need to be sure that it's being done correctly.
Right,
So again, if you're just seeing this part of the video, we would have you contact your EQRO reviewer if you're going to be doing sampling. So now let's move on to step 7. Implementing your intervention and improvement strategy.
Yeah.
And in this instance, we've already identified that intervention as the Seeking Safety Treatment Program. But when you're thinking about interventions, you need to think about how that intervention relates to the causes and barriers that you identified earlier.
Right.
You need to think about how it can be culturally and linguistically appropriate to your population. And it needs to be something that eventually you can implement system-wide. So if you start small with one school district, if you start small with one area, can it be something that you can do system-wide and it can be implemented the same way? So again, so that you can compare the information and see that it is being utilized the same, and you can compare those efforts. Also, it shouldn't be a one-time thing. Interventions need to be something that would be repeatable, something that, because if you can do it one time and effectuate results, then really a PIP is not where you need to be. A PIP, performance improvement project, is not where you're going to see improvement or outcomes, because the performance improvement project is designed so that something is repeatable and you see changes and you're able to implement, or you're able to measure those changes as they go over. So why don't we talk a little bit specifically about what the interventions are in the Seeking Safety model, and just go through those briefly about how they will be used with this population.
Well, one of the things that's great about Seeking Safety is it has a lot of very flexible models, and very much involves the clients themselves in prioritizing which module they start with and what's most relevant to their needs. And so there's a certain kind of collaborative spirit with this particular treatment approach. And it is one of the best, I think, treatment approaches to a core substance abuse program, and it's used both for youth and adults, and particularly for individuals who've had any trauma and stress experiences. And even for those who haven't had trauma, they give the modules really rave reviews. And so the thing that I have seen in using it in my programs is people will latch on to their therapists or their groups or their modules and literally carry around their toolkits in their purse and things, and they'll use those things to kind of remind themselves of coping mechanisms, resilience strategies, their own triggers. It's really a very strong clinical model. And so what you would want is, once people have been motivated to join the group, is to match them with a group that is convenient, where access is not an issue, and have skilled therapists. And you can get trained and certified in this module as well, which is great. And so I think that would be one of the ways to make sure your intervention has fidelity and quality, is making sure the staff have training and good supervision around how they implement it, both individually and in their groups. Okay,
so to practically put that into idea, we would start an intervention with screening the youth, and they use CRAFT is the name of the screening tool?
Yes, CRAFT is a test You know, it's a validated screening tool. It's actually used in several counties for screening youth, and is a very effective, non-threatening, not long, because kids will tend to not want to finish it if it's really long, screening tool, but it raises to the awareness that yes, I need help and I might be open to participating in some treatment. And
Okay.
so step one, craft.
And then motivational interviewing to determine their participation in seeking safety. And in this particular instance, we're looking at a 12-week commitment to participation.
Yep.
And then after that 12-week seeking safety intervention, they will then be screened again.
Yes.
Okay.
They'll have another assessment, and this is where the county could use they could do a CalOM screening early. It could do the ASAM, a reassessment on ASAM. ASAM assessment is required of all cases you open. It's got 6 modules that are all scored.
Okay.
You could do an ASAM reassessment, which is commonly done to refine your treatment plan anyway. It feeds right into treatment planning. Or you can even use the craft again if you wanted to look at different ratings on the craft. And you would use ASAM or craft or CalOMS to reassess their level of functioning in school, criminal justice, drug use intensity, and some of these other components which we identify in the PIP itself that you will see. And so all of those areas of potential improvement or reduction, which we discussed before, will be measured at the 12-week period.
Okay. So then, when they complete those surveys, they'll move on to step 8.
Step 8.
Where they need to analyze the data and interpret the study results.
Yeah.
And this can be done, in this instance, when we're talking about the seeking safety, this would not necessarily be done every 12 weeks.
No.
Because you will see the results for the individuals every 12 weeks. That when we're talking about analyzing data and interpreting the study results, we're talking about more than just the one individual. We're talking about putting that information together and analyzing whether or not we have seen a movement down in substance use for the population itself, not just for those one individuals. So this might be something that you wouldn't measure every 12 weeks for one person. You would have a set 12-week period or quarterly period where you would put in all the results that you have completed for that time period, all the surveys that are done, and look at those and put them together in an aggregate look.
Right.
So to validly interpret the data, it needs to be done according to that data analysis plan we discussed. So that's another reason why you have to have the data analysis plan. How do you plan to look at it? How often? Who's going to look at it? That kind of thing. And then you need to present that data numerically in a way that people will understand. So if we started with a baseline, again, of 57% of kids dropping out of mental health treatment, then at the 12-week period, we would assume want to see that of all of our kids in mental health outpatient, not just the ones in seeking safety, that number had decreased. The kids were staying in the program. So, and then of course you want to talk about how if you have this defined, then you can compare the previous baseline to the new data. And the only time that you may fall outside of comparing something exactly as you measured it the first time would be if you had a system type change, or let's say that in this instance, for some reason, CalOMS data wasn't reportable, it didn't come down. You want to note that in your submission or your write-up, because that could impact your results. So these are things, just outside sources that could impact things that you want to be aware of and talk about. So
and that outside factor You always have to have your antennas up about that. It could be everything from a new school requirement that stresses all the kids out, and you have a lot of new behaviors or new issues that are triggering the kids and creating some other situations, or a change in the juvenile hall population as determined by the juvenile court judge. He's not putting substance abuse kids in the juvenile hall anymore. He's doing something completely different. So there are outside factors that can mess your design up, and you just need to be aware of those and look at change or adapting or refocusing your study on what isn't being experiencing that outside influence.
Right, and you want to talk about how that may impact your results.
Mm-hmm.
So you could see if it's a positive focus on a new thing at a certain school district, you could see something that may impact that. If it's a negative thing, you could see your numbers go down. You just want to be in tune to those and talk about how they may affect your particular results. And although you have an evidence-based practice, this outside influence came in, and so we really didn't see what we thought we were going to see in this quarter. So we're going to keep with, we may decide we're going to keep with this cohort of kids and measure them again in 12 weeks when that influence may not be there, and see how we do with that. So that would be a way you could address that and talk about it in your write-up. And then we move to step 9, which is a plan for real improvement. So is what happened truly a real improvement? Did it, is it attributable to only those outside events, or is it attributable to what we have been doing? So this is another area where we may talk about measuring statistical significance. Also, let's say that when we began, we had 57% of kids that were identified and dropping out of treatment, and then at the end we had 55%. Well, was that statistically significant? Did we really make that much of an impact? Is there something else we need to do there? So we need to think about those things when we get to the end of the PIP.
That's why it's nice if you can identify a goal up front, like the 15%, because then you kind of know what you feel is substantive in terms of the change that you want to see. And then you can measure yourself against it.
That's correct. And then step 10 would be where you achieve sustained improvement. And this occurs over time. So this is necessary that you put an intervention in place and you have measured that intervention and you have seen success repeatedly.
Yeah.
So this could take a year, this could take 18 months before something is sustained and you see that it's measured. So this is where you would talk about, we measured after 12 weeks and we had an uptick of, a few percent of kids who stayed in treatment.
Right.
And then we measured again and that stayed the same. We measured again and it went up a little bit more. So are we, by measuring over and over, we're seeing that what we have put into place may actually have made something happen. And when you get to this point, then you're probably ready to make this part of your day-to-day practices. You don't want to get rid of the program because there's always new kids turning the ages of 12 to 18, and there's always new kids that are interested in experimenting or having ending up, unfortunately, with substance use disorders. So it wouldn't be a time to retire this particular incident, but it could be a time to retire this as a PIP.
Yeah.
Because it has become part of your day-to-day practices.
And it is a good thing when you see something that's working well with your core population to kind of integrate it into your core program and keep a focus on the quality and fidelity of the program. The supervisors may continue to want to use that form to check on the skill and capacity of the staff leading the groups and individual. But you don't have to have it as a PIP. You could go on to say, okay, now we're going to focus on this other issue that relates to maybe opioid overdoses, which is a big issue in many counties, and focus on some other challenges in the SUD system. So this is a great opportunity to take one of the evidence-based practices and look at whether it would meet some needs within your own county. And I want to thank Santa Teresa County, that shall remain nameless, for doing some of the staff work that started on this and gave us some of the material that will be part of our web presentation and our YouTube presentation.
And we hope to bring to you another evidence-based practice in our next session. And so maybe that will give you an idea. If you want to do the Seeking First for a while, we may have already given you the next PIP.
Yeah.
We'll see.
We'll see.
Thank you.